Chapter. Good afternoon and good morning, and thank you for joining us today. Before we get started, please remember that this is a listen-only call, which means that I am unable to hear you. If you have any questions as we move along in our call, please reference the box that you should have on the right side of your screen. It would have popped up when you logged in. That box will allow you to send questions over to me instantly, and if I am able to incorporate those into my talk at that moment, I certainly will. However, please know that I will address any and all questions that you have at the end of today's call. If perhaps there is something that you would like to speak to me further about, I will be available immediately following today's webinar, so feel free to call my office at 586-323-3620. Again, that number is 586-323-3620. All right, then let's get started. What we're talking about today is injury to the brain beyond that of TBI. And a lot of times what I have found in over 24 years of practice, that there's different types of brain injury that we don't think of that actually require neuropsychological evaluation. And that's what we're going to talk about today. So the objectives today are to discuss neuropsychological evaluation as a critical first step. In other words, neuropsychological evaluation is very important to diagnose the cognitive deficits, and I would add in that point also the emotional deficits that are going on, and to differentiate exactly how the injury is affecting the brain. And then, of course, to summarize, what we're going to be talking about in terms of the impact on patients that are suffering from the following types of injury to the brain. And just notice the spelling here, actually. At any rate, different type of impact on patients suffering from the following types of injury to the brain. Basically, toxic substances, carbon monoxide poisoning, electrical injury, and work-related injuries. The important thing about these injuries to remember, and that's what I'm going to go into today, is that they have an impact on the cellular level of the brain. What's important about that is that if things worsen over time, is one issue, and the second issue is that you're going to see a multi-symptom package and also a lot of variability. This basically points to the importance of neuropsychological evaluation because there's such a variability among patients, because you really can't predict and anticipate what the impact is going to be upon the brain because everyone is different. In other words, there's an idiosyncratic quality here. There's a lot of variability amongst patients depending upon pre-injury factors of their susceptibility and how strong they are internally, in terms of the brain immune system, etc. But more importantly, because the impact on the brain is pervasive and it's multifaceted. So therefore, it's where you have certain general categories that you see across the particular brain disorder, the individual differences are going to be very specific and variable. So again, this is the Age of Neuroscience. For those of you who have been to my webinars before, you know that my motto is, when diagnosis is cutting edge and any disorder can be treated. So why do we have neuropsychological evaluation? Again, to scientifically measure the brain, to track the brain over time, and to track the patterns that are available that are present in the testing that suggest problems. And it's the patterns that are most important, and I can't emphasize that enough. Sometimes what happens is neuropsychologists get focused on the score. It is not the score that's critical. It's the patterns across the different test measures, which means you need to have sufficient amount of test measures to identify those patterns. And secondly, it is relative to the person. So if you have a very bright individual, an average score is going to be significant. So it's important not to get stuck on scores and to say, well, average is fine. That anyone, again, who has heard my webinars has heard me talk about it before. So again, what would be the signs suggesting neuropsychological evaluation? Well, you may or may not know that somebody had carbon monoxide poisoning or toxicity or something to that effect, but they may have changes that tell you that something is going on. Case in point, we recently had a carbon monoxide case of a woman who was a bus driver. She was a bus driver for a school bus for handicapped children. And she was feeling ill, and she went home and she thought she was fine, and then she came back to work and then she was still feeling ill, and she presented herself at her physician's office with the symptoms of just feeling ill, kind of a flu-like malaise, and being very tired and very fatigued and just not feeling well in general. The physician proceeded to go through a panel of different tests and then luckily decided to do a screen for carbon monoxide poisoning, of which she popped up very, very high. Now, the woman was also a smoker, so she had to separate out what was smoking and what was actually carbon monoxide poisoning. But she came in so high that it was clear that it was actually carbon monoxide poisoning. Then this woman had the good sense, per the direction of her physician, to have her house checked and her car checked for poisoning, and found that neither one of them registered, which of course put it to the school bus. The school bus was ultimately pulled off the lot and then put back again when they had cleaned it out. But the point was that the physician did not know to check specifically for carbon monoxide poisoning because the patient didn't present with, I think I may have carbon monoxide poisoning. The physician stumbled upon it because she was ruling things out and actually doing an excellent job in ruling things out. And at which time the patient said, well, I've been sick for X amount of time, and then they worked their way back to the bus because no one knew that the bus was actually the problem. So it's important to remember that when you see changes in behavior, changes in personality, changes in short-term memory, changes in making decisions, conversations not making sense. In this particular case, this woman's depression just went through the roof and became much, much worse. Those are clues to say, all right, let's do an evaluation. And then through that evaluation, at that point, the patient may track, I haven't been feeling well for the last 2 weeks, ergo then we can work our way back to the bus, or I haven't been feeling well for the last year and pinpoint it back to some sort of toxicity. Those are just very important issues. And again, the caveat here is to remember that the patients may not connect changes in their functioning with the specific event that may become the case. And this is going to be true of all the things we're going to talk about today, whether it be carbon monoxide poisoning or even electrical injury or especially work-related injuries and also toxicity. So again, the value of a neuropsychological assessment, especially in these types of cases, you're not going to find any impact seen on radiological tests until that damage has occurred for some time. So if someone has an electrical injury, and that would be either they've been struck by a bolt of lightning and or they have been injured by their holding onto something and it goes through them, and there's always an in point and an out point for anyone familiar with electrical injury. They may not show up with having any sort of impact to the brain for a year. So you can't rely upon radiological tests to be able to tell you that patient's in trouble. And by the time it shows up on one of those radiological measures, that person has lost their job. Or that child is not doing well in school and has already been labeled a behavior problem. So by the time that you find a finding on the radiological test, the deed is already done in terms of impacting the individual's life. And that's why it becomes very important to pay attention to the symptoms, to be aware that these symptoms may be related to a problem, and to track that through neuropsychological evaluation first, because it's not going to show up on radiological assessment until the damage to the brain has accumulated sufficiently to be able to be revealed on those tests. One of the things that you'll find, and I'm just going to do a short summary of frontal processes, is that when you have any sort of toxicity on the brain or changes on the cellular level, you're always going to hit that frontal area of the brain. Why? Because the frontal area of the brain is so susceptible to anything going on in the brain. That's the area of the brain with the highest level of functioning. It's the area of the brain with what we call association cortex, which is multifaceted cortical connectivity that is going on, and that's C-O-N-N-E-C-T-I-V-T, that is going on between the brain. So as a result, anything that impacts the brain on a cellular level, it stands to reason in all likelihood, in all probability, is going to affect the frontal processes. And so just to be aware that the symptomatology of these issues that affect the brain on a cellular level, which is what we're talking about today when we talk about carbon monoxide poisoning, when we talk about toxicity, when we talk about different aspects to the brain that can impact the brain, electrical injury as well, and haven't talked about work-related injuries. Remember that when it affects on a cellular level, 9 times out of 10, you're going to hit that frontal area of the brain. So be aware of those symptoms that may be emerging. So it's just a reminder that when we talk about the frontal area of the brain, we have 3 functional systems. The supervisory system, it manages emotional functioning. That's why emotional changes in personality are seen associated with these disorders. Communication, that's where they have word retrieval problems. Their communication doesn't make sense. And there's a definite change that family notices or work notices or school notices in the individual's ability to communicate. And of course the output, making decisions and act upon them, writing skills. So to keep in mind that this is the system that will be affected, that we will see symptoms related to cellular injury to the brain. And again, just another reminder of the importance of the frontal processes in terms of emotional regulation. Sometimes emotional changes may be the first sign of a brain injury. And again, it's just a wake-up call. We tend to dismiss emotional changes as related to injury to the brain. What do we do when we see emotional changes? We think, oh, there's a psychological disorder, and we refer them to a psychiatrist instead of a neurologist. So it's just, again, a wake-up call that when someone has emotional changes, and they have not always been there, whether that be a child, adolescent, or adult, and it pops up, don't think psychological first. Think neurological first. Because you can always double back and change and move to a psychologist. But you can't double back and change if you've missed an injury to the brain. The brain doesn't give us that window. When we miss something, it gets worse over time. It doesn't get better. And so it's very important that when there's an emotional change to someone in their personality and how they act and what they're doing, it becomes noticeable. Think brain first, think psychological second. So again, our neuropsychological staff here at our clinic, we are going to decide upon which test to use, and this is just a reminder of the different tests to use to be able to address each disorder depending upon what we know about the impact of that disorder. And generally speaking, when you're talking about some sort of change to the brain, we're going to be looking at attention, language, visual, spatial, visual, perceptual, of course the psychological, and frontal and memory or temporal deficits. And then, again, cognitive achievement is always the background and the baseline. So you can't really make assumptions about the brain, and again, this is just a reminder, unless you've done a neuropsychological test battery. And the art form is not to rely upon radiological assessment to assume what's going on in the brain. It's very important to have that arm of the neuropsychologist, which the neurologist recognizes, to be able to marry the 2 fields together. So we really can make a difference in an individual's life, both in a preventative mode and also impact their long-term graceful aging. So now we're going to talk about what is brain injury beyond that of TBI. Everyone thinks of brain injury as traumatic brain injury, and there are other types of injury beyond that of TBI, and this webinar is designated to identifying that. The primary issue of the disorders I'm going to talk to you about is the cellular impact upon the brain. The changes in the connectivity, the way the neurons connect. And what happens is that when neurons are connecting abnormally, then there's cell death. When there's cell death, it can lead to more cell death. Undamaged cells aren't monitored, which again leads to abnormal connectivity. And the pattern goes around and around and around. So be aware that when there's cellular impact to the brain, which is what we're talking about with these disorders, that it changes the way the brain functions, and it has far-reaching consequences, that over time the injury becomes worse. And I'm going to repeat that because that's so critical. Over time, the injury becomes worse. We are used to operating under the idea that injury to the brain gets better, that it gets better over time, that when you have a traumatic brain injury, you have a 3 to 6 months window, and then you get better. Spontaneous recovery, and everybody gets better. Not with this type of injury. Not with this type of injury. It does not get better over time. It gets worse over time because you're affecting the cells. And as the cells become worse, you have these patterns, these cyclical patterns that are developing. And so it does not get better over time, it gets worse over time. So what do we find with toxic substances? And again, this is a general overview, and every case is different. But you're going to be looking for motor and sensory deficits. Why are you going to be looking for motor and sensory deficits? Because with toxic substances, it tends to hit those areas. It tends to hit the attention problems. It tends to hit frontal processes. You see personality and emotional changes, and again, it becomes worse over time. So take the case of the farmer who has been in the field spraying. And they come in, and over time, their personality is changing. They now have motor problems. They have maybe some tremors that have developed. They don't have any sensory feeling in their fingers or in their toes. They have frontal processes. They're not communicating. They can't attend. And you begin to do a history, and you track that they have been exposed to these toxic substances. Agent Orange is a big one. Agent Orange, when people are exposed to that, it risks their immune system over time. Personality changes are well documented. Again, motor and sensory, same issues that I have listed here. So it's important to be aware that when people are exposed to toxic substances, that over time the injury gets worse and it affects the brain in a pervasive manner. Carbon monoxide poisoning is the same kind of thing. And what happens with carbon monoxide poisoning is that initially there's a flu-like symptom that happens. People become very tired, very fatigued. They may have a kind of a mild temperature going on. They feel very ill. They can't eat. They can't digest because it's getting into the system. And again, with carbon monoxide poisoning, it's well documented, well researched, that it changes the cellular level of the brain. It changes what's going on the cellular level, and it changes the cells in terms of opening and closing the porousness of the cells, which is the same as electrical injury. So these individuals can be at risk for seizures. Again, it hits the frontal processes, memory processes, visual spatial deficits. With carbon monoxide poisoning, it again can become worse over time because of the changes in the cellular level. When you have adults, one of the things that you're going to see with carbon monoxide poisoning is memory problems get hit pretty hard pretty quickly. And then you see the personality changes. Depression is increased tenfold. And again, you also see the frontal processes as well. With children, depending upon their age, and again, the younger they are, the worse it is, you really see that frontal lobe being affected big time. We had a little girl who had carbon monoxide poisoning. Actually, she did in her mother, and it was over a period of a year. And this was when she was a baby. By the time we tested her when she was 7 years old, she was she hadn't acquired reading. She was not reading. She was not intelligible all of the time, only some of the time. She had, basically, she was really having a terrible time acquiring language. Visual spatial deficits were huge. She had lots of distortion seen on testing. Emotionally, she was very fragile. She also had a ton of colds, always getting sick because her immune system was more vulnerable. And she simply was not functioning. She was like 2 grades behind, if not more. And it was really carbon monoxide poisoning that got worse over time. Her mother's main symptoms was memory. And it was short-term memory problems. And she also had changes in personality that were huge, mood swings, emotionally labile, couldn't predict her behavior. But the key differences between the two is that the strong problems for the mother, the primary problems for the mother, was the emotional issues, terrible mood swings in behavior, and the memory. For the child, it was learning language, acquisition of language. And again, we could have easily labeled her autistic if we didn't have the history, or no one knew to go back and do the history. So it was acquisition of language, emotional, all the things that you would expect to see when you have a baby whose brain has been impacted early. And the same would be true also of any sort of early pediatric injury to the brain. Anytime that you injure the brain either before or after birth, you're always at risk to affect the frontal processes and have a very blatant, pervasive impact to the brain that will include all these areas. And those are the children that we're misdiagnosing as autistic. So I didn't include that in here, but remember, there's a lot of brain injuries that occur due to whatever has happened at the time of birth or before birth or after birth than the first year of life. And that can have a huge pervasive impact on the brain because it hits the oxygen level of the brain and also any sort of anoxia, and that will, of course, affect the frontal processes and then all the development of the child through time. The key thing about electrical injury is it's well documented in research. It gets worse over time. The other key piece is they have a lot of symptoms that are similar to multiple sclerosis. They have a lot of pain, a lot of neuropathic pain, a lot of burning, neurasthesias in their feet. The one man that we evaluated and actually tracked over a period of 6 years, he had an electrical injury. He was holding on to a faucet when a bolt of lightning struck, and so he literally, there was a point of entry and a point of exit in terms of the electrical shock. And what happened is the symptoms just started to get worse and worse over time. He became more fatigued. He had all kinds of problems getting up. He couldn't get up out of bed in the morning because he couldn't move his legs, and that is with the symptoms similar to multiple sclerosis. Eventually began to hit the frontal processes. He had learning problems. He had huge memory problems. But the key with the electrical injury is that it really hit the motor and sensory system. There was so much fatigue and so much pain. He had migraines. He was in pain every single day, with vision problems, all kinds of issues, and then tremendous personality changes. So again, it hits the brain on a pervasive level, but he got worse over time. He just got worse and worse over time. So then when they went in and did a PET scan, which was probably about 2 years post-injury, the primary impact was on the thalamus, which is a relay center to the brain. So if you are familiar with the brain, by impacting the thalamus, it's like it would impact the whole brain because everything coming into the brain was getting affected by hitting that major relay center in the brain. So it just is a wake-up call to understand that electrical injury can be pervasive, and again, it gets worse over time. It doesn't get better. There's a lot of research to document that. Work-related injuries, and again, this is a little bit different from what I've been talking about in terms of the cellular injury, but it's just a wake-up call to remember that a lot of times you'll get a case in, and the primary issue is they've broken their arm. And my case in point is I had this woman who came in, and she was referred to me initially for hypnosis because she was in pain with this arm that had been broken, and they had had a hard time healing it because it had been so badly broken. She had fallen off of a chair at work. And in the process of trying to do hypnosis, her communication was so odd and that it didn't make a lot of sense to me. And so I had her husband come in, and in the process of interviewing him, he said, she's had a lot of memory issues. I said, really? And so long story short, it turns out she hit the desk on the way down when she fell from her chair. So she fell from her chair, hit the desk that she didn't remember, and then broke her arm. And a lot of times when you get a patient describing an injury, they leave out pieces because they don't remember because there may have been a loss of consciousness somewhere in there. So we focus on the primary symptom of whatever it is that they're complaining about, whether it be the hand or the arm or whatever, and we don't think about the brain. In this woman's case, her brain injury was huge. I went in to do initial memory testing, and it was a mess. It was just a mess. So her major issue was actually injury to the brain. It wasn't injury to her arm because the injury to the brain was so awful. But in the meantime, because no one saw that and they had been treating her psychiatrically, and they gave her medications that actually increased seizures. And so by the time that I got to her, she was having full-blown seizures, and then she moved into psychosis, and we actually never managed to recover her because I had run in too late. So the point is that you'll get someone in with a presenting symptom is they cut their hand, and all the effort is being devoted to fixing that limb or whatever that injury was, and we don't think to ask them, did you ever lose consciousness? Do you think you might have hit your head? Or the more important question is what? How's your memory doing? And to bring in the significant partner or whoever is significant in their family to find out just what has happened. Because when you rely upon patient report, you're getting what they think. And more often than not, you're not going to get the whole story. So it's, again, a wake-up call to bring in whoever they live with to find out what are the associated symptoms with this particular injury, and not to simply focus on whatever they're presenting. Another case in point is I had a case where I was called into Canada, and basically the focus was this man had lost both of his legs. So obviously that was the focus. But no one thought about the fact that in the process of the injury, the accident that caused the loss of both legs, he had injured his brain. And he had a significant brain injury. So again, in treating the patient, if you focus on that broken limb or whatever has happened to them, and then you forget about the injury to the brain, you're going to miss a big piece in their care, not to mention the fact of what the impact is going to be on graceful aging. And in addition to this man who lost both of his legs, what happened to him is he went into shock because of the accident. And so it was not only the indirect blow to the brain as a result of the accident, it was also the fact that he went into shock, and that impacted the brain. Which brings me to other issues. We've had other cases where we've had a thyroid disorder that wasn't diagnosed. There's a lot of the medical malpractice cases where you're definitely going to have an injury to the brain. So do you focus on the fact that the child didn't have thyroid medication, or do you go back and figure out that that child did not have what they needed and within a very short span of time, they're obviously going to impact their brain. And the important thing with children to remember is the younger they are, the more you're going to hit that brain pervasively, and you're going to hit that frontal lobe, and you're going to affect their ability to acquire language and function. At the same time, they're automatically slated to be at risk for Alzheimer's and less than graceful aging. So what's the future impact? Again, it's very important to remember that a lot of these disorders are progressive. And when it's injury to cellular level, it does not get better over time, it gets worse. So you want to be able to differentiate between children and adults and the time of insult, because children are going to have more pervasive impact, adults are going to have more specific symptoms. By the same token is that when you affect an adult and they are in their 50s or 60s, you're going to have a high degree of probability of impacting their ability to age gracefully. There will be a high degree of probability that they will be at risk for dementia. The other piece that I want to mention is the impact of continual pain. And sometimes we tend to negate pain and not really realize the impact it has on the person's life, on their ability to function, on their ability to get up in the morning. I mean, I know when I have a headache, I don't function as well through the day. Well, imagine having a headache every day of your life. Every day of your life, you wake up with a splitting headache. And how do you get through the day being in pain? And these injuries, especially electrical injury, they are in continual pain. They're in continual pain because of how that injury hits. And so it's very important to remember that these individuals, when they are dealing with continual pain, don't function. They can't have good relationships with their family or significant people in their life. And they're always tired. Their personality changes. They cannot work because of the pain, and they're so miserable, and they're going to make mistakes. It's automatically going to affect attention and concentration. And then be able to document, are the headaches migraine headaches? Is there vertigo? There's a constant feeling of being out of control. It affects sleep. And again, the impact of poor sleep, we now know that there's emotional lability just from sleep deprivation. We now know the interaction of age, sleep, and health. Less than 6 hours of sleep results in the potential for sleep deprivation. And what? Changes in the cytokines, increase in obesity, metabolic changes, immune and vascular markers. So what's the key issue here? You have changes to the brain on a cellular level. That affects the sleep cycle, which then affects more changes on a cellular level, and it cycles back again. So I can't begin to tell you the pervasive and interactive cyclical effects of cellular injury to the brain that causes more injury every day, not recovery, not less injury. And again, of course, it's going to leave you at risk for less than graceful aging. So what are the markers of cognitive decline? It is increased brain inflammatory, cytokine, C-reactive protein, homocysteine levels, an increased influx of calcium. All of these issues that you see here, oxidative stress, free radical production, which lowers the immune system, increased CSF, cerebrospinal fluid, cortisol, and HPA activation, decreased regulation, increased insulin resistance, decreased volume of hippocampus, or hippocampal function. All of these issues are the cellular changes. So again, these are the markers that we know as cognitive decline. These are the same cellular changes that take place when there's toxicity of the brain. These are the same cellular changes that take place when you have carbon monoxide poisoning. These are the same cellular changes that do take place when you have electrical injury. These are the same cellular changes that do take place when you have anoxia at birth or some sort of a malpractice situation that occurred where a child was not attended to, and as a result, something happened to their brain. Another example of a child had a mild stroke because they were left in an incubator and they did not keep the temperature constant. So there's all these issues that can happen to babies, all these issues that can happen to individuals that affect the brain on a cellular level. And again, just to remember that you can impact all of these issues, can impact all of these cellular changes that then impact more cellular changes, and it just goes on and on and on, a cascade of effects. And it's very important to track that and to be aware of that. So basically, to move on, I'm going to just spend a few minutes about what we do at United Psychological Services. And that is that we are now doing both a forensic and also treatment report to be able to facilitate the process of treatment and provide the medical team what the medical professionals need in terms of information, and at the same time to abide by the court standards and what is needed in court. It's been an excellent, excellent combination. We're very pleased to be able to offer that to you. Again, the diagnosis is key. It's very important to plan over time for changes to the brain. One of the important things, and this is an issue for anyone who's doing a life care plan, is to remember that these disorders get worse. So what are you going to need to put into the report or the treatment plan for that individual? That they have testing on a yearly basis. It's going to be important that they have a neurological consult on a yearly basis, a psychiatric consult on a yearly basis, that things are tracked over time on a yearly basis, not every other year, not every 5 years, but every year because of the impact on a cellular level. And to factor that in terms of the cost for them, that they have these evaluations continually, that those issues are addressed. Because there's so many things that can happen, because again, I can't say this enough, you're changing the brain on a cellular level. And the impact is huge. The cascade is tremendous. So we also have cognitive training, brain training, and all kinds of other services that can be offered to the individual. So basically, what we're talking about is that we have different services that we offer. We're just going back to give you what we have that we can offer to you. One more. Yes, there we go. Family therapy is very important. And the reason why I wanted to double back and talk about family therapy is that when you have a sick child in the family, it changes the structure of the family. And unfortunately, many parents are unable to keep the marriage together when you have an ill child that's impacting the family. The other piece that happens is so significant when you have an ill child that's impacting the family is that the other children then become very jealous and there's sibling rivalry, or you have a child who's not getting attended to. And so at the end of the day, you have children in the family that are on some psychiatrist's couch and they're saying, well, I wasn't very important because I wasn't the child that was ill. So we really work on family therapy because it's very important when you have someone who's ill or a parent who's ill to recognize that all the family members are involved. It affects the family system tremendously. I'm going to address, we had a question about cognitive training and brain training. It's two types of training that we offer. Cognitive training is our interactive metronome program that we use, and that takes care of attention deficits and focus and attention, and also helps the energy for the individual. And it also addresses visual spatial deficits as well, and reading deficits. And that's like the first leg when we have a brain injury of our training program. And then we do our brain training where we take the individual's deficits and specifically design a program just for them. We take their deficits and specifically design a program just for them based on what we found in their deficits in the neuropsychological evaluation. And then we hit the frontal and memory deficits. The cognitive training program does not hit the frontal deficits. We've had to actually create our own materials, and it's been very successful. We're doing pre and post testing so that we know the training that we've created works. and then we're training individuals in their specific area of the brain where there is a problem. So basically the idea is to remember from this slide that you want to be able to have continual reassessment and also family therapy. And again, just to talk about what's unique about our service, we specialize in neuropsychological evaluations. Obviously, we have a lot of experience in doing neuropsychological testing, pediatric and adult. And we write extremely comprehensive reports. So you can take that report and use that. We always get compliments about our reports. And we just had a recent case where the individual called and said, I took that report and went to a school meeting, and that's all they needed. And more often than not, the school never has to do any testing. We do all of the tests. Where it works for the case is that then the testing that we've done as part of the team is now incorporated to the school record, and it becomes more powerful for the case. So it's worked out very well. So again, in terms of, we provide a comprehensive treatment report. We have a team of specialists been involved with brain injury for 20 years or more. We also manage the case as well in terms of interfacing with the different specialists, the primary care physician, the neurologist, and also the attorney. And we do develop a specific treatment plan, but we can also develop a cognitive therapy program and a brain training program that can be implemented anywhere in the country. Our materials can go. We have an individual who would travel to the person's home and explain all the different things that can be done. So we definitely travel and can recreate our program anywhere. So again, just to summarize, we have a treatment team here at United Psychological Services, and you can see all of that on your screen, where we have a forensic team, and we also have a consulting forensic team, neurologist, neuropsychologist, psychologist, speech and language, and brain training. And so we really offer one-stop shopping where we cover everything here at United Psychological Services, and we can handle all the issues. And so you have one person coordinating all of the things that are needed in the person's care, and that's what I do as the director. I interface with all of the professionals and also get a school team together. In the past, we got a whole school team together and had a conference call and addressed the child's needs. The beauty of that is that we had the school meeting prior to the IEPC, and anyone who knows the IEPC or the IEP, it's the interdisciplinary education planning team. And so before they had their meeting, we learned from the school, and also before we, our staff produced the treatment report, we learned from the school what the problems were. So therefore, when our educational specialists went in to meet with the school to do the IEP meeting, they were already aware of where the school was coming from, and it worked out very well. So we had a case conference with the school to find out what they thought the child's needs were. So we were very creative and very innovative in basically working with the different professionals that are involved, learning about exactly what the problem is, and then interfacing that with the report to be able to prove that there's an injury, at the same time doing the right thing by the patient to make sure that they're taken care of and have an excellent treatment plan. And that's always the difficulty. It's always difficult to be able to satisfy the court requirements and at the same time take care of the patient. And that's why we found it just extremely helpful to separate out the forensic report from the treatment report. And so both facets are being taken care of, and the individual gets just the best of care that they could receive. So again, United Psychological Services, a multidisciplinary clinic committed to providing testing, diagnosis, and support to individuals dealing with a number of psychological and neuropsychological disorders, emotional as well as brain-based, all in one location. We diagnose early. What's important with individuals to start a baseline, especially with children. The injuries that I talked to you about, carbon monoxide, the electrical injury, we documented those injuries over time. Even the adult who had the head injury, we documented over time who fell to show that actually she did have a head injury, even though the focus was on her arm in terms of that work-related injury. We can train the brain and improve functioning, and it's a new day, and we're finding all kinds of creative ways to help the individual and also to satisfy the requirements needed to prove there's an injury to the brain. Thank you so much for your time. Hopefully I've answered all of your questions, and I appreciate you all being here, and I hope you all have a great weekend. Thank you.